ගින්න මට කතා කරනවා ඇයිද බලන්න ජයමල් පොඩ්ඩක්.
Good evening, everyone. I welcome you all to this volume 2 of the Surg Ahead. So today the session will be done by the Sri Lanka Association of Surgical Oncologists. It's on breast cancer. So we have several resource persons and 2 moderators. The resource persons are Dr. Kanishka Silva, consultant oncosurgeon from Apeksha Hospital, Dr. Chaturani Dharmaratna, consultant oncosurgeon from United Kingdom, and we have Dr. Nuraj Joseph, consultant oncologist from Hambantota Hospital. Also, we have Dr. Lakmali Paranaheva, consultant radiologist from Masari Hospital, and Dr. Priyanka Abhigunasekara, consultant histopathologist from Apeksha Hospital. And the 2 moderators are Dr. Anju Kumar Singh and Dr. Heshan Sirivardhana, both working at Apeksha Hospital. So shall we start, Anuja and Heshan?
Good evening to all of you. Hope that you can clearly hear us.
Yes, we can hear us, but better if you can increase the volume a bit.
Okay. So we warmly welcome our expert panel and all the participants. There are a few messages before we start our session. Please turn on the mute mode of all of your devices. And we are going to discuss at least 2 or 3 cases today. And at the end of each session, you can bring up your questions or queries from the Zoom chat. So we'll move to the first case.
Can you share the screen? Can you see our screen?
Yes, we can.
Yes. The first case, actually, the patient was referred by a GP to a surgical clinic, and she's a 38 years old lady, presented with left side breast lump for 1 month duration, and we couldn't find any additional risk factors. And on examination, there is a left side 4 into 3 centimeter size suspicious lump in 12 o'clock position, close to nipple areola complex. No clinically palpable axillary lymph nodes, and right breast and axillary examination remarkable, and the rest of the general examination is normal, and ultrasound scan left breast to Can you hear us?
Yes, we can.
Okay. The ultrasound scan, there is a left breast 12 o'clock lesion in the subareolar region, and it was a bidat 5 lesion, and the size is 3 centimeter. No suspicious axillary lymph nodes, and the right breast and axilla is normal, and FNAC was done. It was C5. Then the first question goes to hello. Hello, can you hear us?
We can hear you, and we can see that FNAC.
Hello,
yes.
Can you hear us now?
Yeah, we can hear you.
Okay. Okay, the first question goes to Kanishka sir. Sir, what is your approach to this patient?
Now, one little question. Can you hear me? Yeah. Right. Now FNAC was from the lump itself, or where was the FNAC done on what? On the suspicious axillary lymph nodes, on the breast lump? Hello?
Yeah, it was in the breast lump, sir.
Yes, sir. There is lump.
Yeah, I mean, this is a 38-year-old lady whose breast examination and imaging has come as suspicious for breast cancer. So the ideal test for this kind of patient is not the FNAC. The FNAC just gives cytology. I mean, basically, if you do FNAC of the breast lump, you will get a histology subsequently. So you are basically wasting two needle tests. So might as well, I mean, I wouldn't have done FNAC in the first instance. I would have then straight away gone for a co-biopsy, true cut biopsy, which gives the histology. And then also it gives the grading of the tumor, the type of the tumor, the grading of the tumor, and immunohistochemistry, especially if you are going to downgrade the tumor. All those information would have been achieved, got by the co-biopsy. And this patient, though she is 38 years old, I mean, she's pretty close to 40. I mean, I would have done a mammogram on this patient because, you know, that investigation is missing here. The mammogram gives additional information whether there is microcalcification and whether there are other, you know, suspicious areas and, you know, other breast as well. So, so those two investigations are primarily required, and a co-biopsy of the tumor would have been is required. And if the suspicious, the nodes are suspicious on ultrasound, I would have got at the same time then a FNAC of the axillary lymph node, just to make sure that they are positive or negative. Was there no suspicious axillary lymph node? I can't see the thing.
So actual examinations are normal, sir. Those nodes are not suspicious.
If there were suspicious nodes, of course, I would have got the FNAC done on the axillary nodes. But if there is no suspicious nodes, there's no place for FNAC or the axillary nodes. So the basic investigation will have been the mammogram, and in addition to what you have already given here, and a co-biopsy. So I think that would be the required thing, and this can be done in. I think most of the hospitals have facilities to do that. Co-biopsies. I know there are maybe issues of getting mammograms in some places, but that can be organized. I think that's the sort of thing I would have gone for. Right? Yeah.
And sir, one question. Will you always do a ultrasound guided co-biopsy, or you do a blind biopsies at clinic level?
I actually prefer to do ultrasound guided co-biopsies. The reason being, sometimes when there are larger masses, now this lump is now clinically the lump is like 4 by 3 centimeters, and the ultrasound has given it what's the size of the ultrasound that was on clinical examination is 4 centimeters. Sometimes you see the ultrasonically smaller lesion, but the palpable lesion is larger. What happens is around these breast cancers, you get like a fatty area collected, like a what you refer to as a pseudolipoma formation. So and that and if you do blind course, the unguided course, sometimes you can end up getting those surrounding area, and you get fat and unrepresentative samples. So if you get a guided co-biopsy, you avoid all that, and you can get it directly from the most suspicious area of the mass can be accessed, and the biopsy can be done, and you are more likely to get a representative sample if you do ultrasound guided biopsy. So I would prefer that. Yes. And also there may be other lesions which are not sometimes palpable. So if the ultrasound scan is done, you can do additional lesions, if they are there, those also can be done can be biopsied. So lot of hassle will be avoided, and the time delay would be reduced if you can get it done that way.
Okay, sir. And the mammogram, there was a left subareolar bilateral 5 lesion. And the next question goes to Lakmali madam. Madam, what are the additional information you would look for in a mammogram, which should help a surgeon like to see?
Yeah. Hello. Can you hear me?
Yes, madam. We can hear you.
Yeah. So the additional information is mainly when you see ultrasound guided ultrasound, you see a lesion. If you do a mammogram, we can see other lesions in the same breast and the other breast. So it's important to see microcalcifications and any other satellite lesions or other lesions in the rest of the breast to make sure that it's a single or multifocal disease. Also,
Okay,
you
madam.
can.
What about the skin thickness?
Yeah, skin thickening and areola thickening can be seen to
I think madam's concern has lost. We'll try to connect her.
While we are waiting for her to join, can I just ask a question from Kanishka sir?
Yeah.
So what do you think of now if you have got a BIRADS 5, I think Lakmal is back.
sorry, I
Yeah.
got disconnected. So sorry. So carry on.
Sorry.
I'll explain about the mammogram later, or you want me to?
Yeah, just a question. So now my question is, when you've got like a BIRADS 5 lesion and this is a sort of a 4 centimeter lump lesion, and it's a 38-year-old female. Now, when you are doing the ultrasound guided co-biopsy, now this is mentioned in the ESMO guidelines also. What is your view on putting a clip then and there? It's a BIRADS 5 lesion. So why at the time you are doing a co-biopsy, what do you think of putting a clip so that we have this high likelihood of neoadjuvant chemo?
Yeah.
But what are your thoughts on that? I would like to ask you and as well as Kanishka from practical point of view.
Yeah, it's possible to do, and it's easier if you do it at the same time. But we always sort of wait for the surgical input, because if neoadjuvant is being given, if it's 4 centimeters, it's probably easy and convenient to do it at the same sitting.
Yeah, actually it is like this. Now, most of the time, this patient would have been seen by a surgeon. So if he could envisage where there might be a neoadjuvant chemotherapy given, because say, for example, a 38-year-old lady with a larger lesion, and if you are especially considering conservation, and if you are suspecting the possibility of aggressive disease, where like triple negative or HER positive, which you wouldn't know until the histology comes. But if you are suspecting that this patient might end up getting neoadjuvant, I would personally ask the oncoradiologist, I do some at times, whether they could put a at the same time they do the biopsy, whether they can put a needle in, put a marker in, a titanium clip into the place. So it's actually it's a good idea to do. Only thing is, all settings whether we can put the clips is because sometimes the clips are we just put clips and things like that because the proper markers are a bit expensive, and whether to get it in is always not practical in some places. But at least if reasonable number of selected cases, we could do it in the first setting. And we do in some, the cases where we think the neoadjuvant might be used. So, I mean, it's a good idea if you can put it to everyone, I suppose. But it may or may not happen due to some constraints due to the facility levels that are available. Yeah. Lakmal Yati, you can continue a discussion on mammogram. Yeah.
Yeah. So, yeah.
Madam, actually, we could hear half of your description.
Yeah, so what we are looking for is whether there are other lesions in the same breast or the other breast, and microcalcifications, and also the involvement of the skin and the nipple areola complex and the lymph nodes. So which can be, be of additional information.
Okay, madam. So why sometimes I mean we recommend to do core biopsy before mammogram. What is the reason for that?
Reason is, one thing is the pain, because just after the biopsy we can't do a mammogram because of the compression. Patient will be uncomfortable. If there's a hematoma after the biopsy, then it will be very uncomfortable to the patient. And also because of the distortion that happens, the mammographic also will affect. We can biopsy. There might be distortion or hematomas can cause some additional shadowing on the mammogram, which can be interpreted wrongly. So because of that, we always do the mammogram before the biopsy or about a week after the biopsy.
Okay, madam. Madam, sometimes taking an early date for mammogram is difficult due to various factors, especially in peripheral hospitals. So what are your suggestions to overcome this problem?
Well, that's the issue. So the thing is, all the mammograms are referred by the surgeons. So if you have a quota for emergencies and say there are of mammograms per day, so if quota for routines and if you have quota for urgents and you have a good rapport with your radiologist, I think it shouldn't be a problem to solve it. Because if the mammogram is available, it doesn't take everything is and then give an appointment. If you have a quota always to do the urgent ones, then that should probably solve it.
And hope Dr. Chaturani is with us.
Yep, I'm with you guys.
Dr. Chaturani, can you hear us?
Yep, I can hear you. Can you hear me?
Okay. Yeah, we can hear you. So do you have any suggestions or your comment on this case? Do you have any different approach?
So if this patient comes to our breast clinic, we do have our one-stop breast clinic. The initial thing we do is we give like a P categorization after we examine the patient. I'll tell you why we give that. P1 and P2 are benign lumps. If it's a normal breast tissue, we call it a P1. P2 is like fibroadenoma, cyst, and fibrocystic disease. P3 is for intermediate lesions. Can you hear me?
Yeah, we can hear you.
Okay, so
we can hear you, but
I'll switch off my camera. So now can you hear me?
No, we could hear you before the with the camera on and without both ways.
Yeah. Okay, so P3 is for like intermediate lesions. P4 and P5, just like telling with the mammograms by Birat's categorization, P4 and P5 for cancers. So once I give that categorization, I usually give it before I see the mammograms or the ultrasound scan, when I see the patient and examine her clinically. So when she goes and has an ultrasound scan, then the radiologist puts down the radiological categorization. Like we don't have the Birat's in UK, we have ultrasound 1 to 5 and mammogram M1 to M5. In this lady, because she is less than 40 years old, she would not get a mammogram unless the radiologist thinks the breast is very fatty, it will show the lesion properly. Ideally, she would have an MRI. So the radiologist usually call me back and say, Chatur, request an MRI. That's how the usual thing will go. So once she has had an ultrasound scan, so I have to compare my findings, clinical P findings, with the radiological M1 to M5 or U1 to U5 findings. The reason I said that, because of the question Anuja asked about the clinical core and the ultrasound guided core. So if my category, if this is not the case we're talking about, if I have put as P3, if I don't think this is a cancer but intermediate, and the radiologist has put as like BIRADS 4 or 5, then the radiologist will do a biopsy. But if I have put like a P3, but the radiologist has put as a BIRADS 2 or 1, so the radiologist will not do a biopsy, but I have to do a clinical core biopsy. That means my categorization is higher than the radiological categorization. Anything beyond BIRADS 3, our radiology department do guided core biopsies, but anything under BIRADS 2, we have to do the biopsy. Unless it's a fibroadenoma, they want to confirm or something like that. That means like there are mammographically occult lesions that we can miss. Mammographically and ultrasound, under the ultrasound also, we can miss lesions. I have had 2 patients like that. Patient comes with a breast lump, but we can't clearly feel a lump. It's a vague, like nodular area there. But when you do the mammogram, this happens in younger age group. When you do a mammogram and when you do an ultrasound scan, you can't clearly see anything. So I did the core in both of those patients. They became cancers. So they should have an MRI, but MRI, you can't do it on the same day. So it takes, in the UK also, it takes around 1 week or 10 days for us to organize an MRI. So in between that time, we can get the biopsy and the MRI, everything together. So the other thing we do as a routine, if the radiological imaging is suspicious of a cancer, we always put a clip. So the decision to operate depends on the biological profile of this lady, whether it's CRPR positive, negative, or HER2 positive. So even if the breast, according to this lady, the cup size is 38D, and that means even a 3 centimeter lump, you can offer upfront surgery if the biology warrants that. So the surgical decision is not taken at this level. We have to wait for the biology of the tumor. And when we put a clip, if the patient is not having neoadjuvant, when we are doing the surgery, we do like x-rays after we take the specimen out to see the margins. And when you have a clip, you can clearly see which margin is closed, and we can do another excision of a margin and send as a separate margin, which will avoid further surgery. So not just for neoadjuvant, even for the other ones, for upfront surgery, having a clip is advantageous. And one more thing, because she's 38 years old, according to the current guideline, we would offer her genetic testing, because the further adjuvant treatment and everything will vary depending on her BRCA status. So I would offer her genetics testing after seeing the immunoprofile and the tumor biology of this.
Sorry, Dr. Chaturani, for disturbing you. I think we are going to discuss during the rest of the discussion about the surgical principles and the genetic screening for this lady.
Okay.
Right. So for Lakmali madam, since this patient is 38-year-old, we would expect her to have a dense breast. So what is the role of mammogram and MR mammogram of this type of patients for the primary assessment of the cancer?
Yeah, because since it's a suspicious mass, a mammogram is necessary at this stage 38. If the patient is suspicious clinically and ultrasonically, we usually proceed with the mammogram. But since it's a young, most likely the breast would be dense. If the breast is dense, definitely a mammogram, MRI could be helpful. Because, MRI could be helpful because to see, for instance, especially in breast where mammogram and ultrasound cannot be 100%, might not be 100% acute. So MRI is available.
Okay. So if you see any other lesions than the mammogram in the MRI scan, are there facility to biopsy these abnormalities?
We don't have the facility, but if we see mammogram, focused ultrasound, which can be helpful in detecting the lesion, but mammogram guided by not available at the moment.
Okay.
Okay. And the biopsy came as invasive breast carcinoma, NST type, and immunohistochemistry, it's ER/PR negative and HER2 2+. The next question goes to Priyanka, madam. Madam?
Yes, good evening.
Madam, how many cores do you need?
There's no guideline in Sri Lanka as to how many cores we should take, but usually for us, if there are 2 cores with adequate amount of tumor, that's enough. But I think they recommended around at least 4 cores to be taken. But in Australia, I heard that they recommended around 6 cores from a lesion. So I think it depends on the radiologist. If the radiologist is confident that they have taken enough tissue, that should be enough for our purposes for diagnosing, grading, and immunohistochemistry. Usually for immunohistochemistry, I use about 2 cores with adequate, if there's tumor. The problem comes when there's no tumor in the cores, then only getting more cores would be helpful that you won't miss it.
Okay. Lakmali, madam, how many cores do you take?
Yeah, it's again, as madam said, the tumor is big and you get a good core because you see it once you take. Either 14 or 16 gauge needles are used. If there's a big core, then I take 2 or 3. But if it's small, sometimes the lesions are very small, so it's not easy to take a good cores. If the lesion is how many times puncture, you get a small bit of tumor. So in that case, take multiple cores. But if it's a big tumor, about 2, 3 or 4 cores I will take.
Okay, Priyanka, madam. So what are the other additional information you would gain by doing a core biopsy when you compare to a FNAC?
Yes, previously we used to diagnose breast cancers on FNAC. Now, primary diagnosis of breast cancer, core biopsy is the recommended method. So, actually having core biopsy is very convenient for us because we are more confident of the core biopsy for diagnosing breast cancer. Because on cytology, sometimes it can be quite tricky for diagnosis of low-grade carcinomas, and lobular carcinoma can be very tricky on the FNAC. So because you're in the FNAC, you're seeing individual cells and you're looking at the nuclear features and cytological features, but you don't get an architecture, right? But on the core biopsy, you're seeing the architecture of the tissue, and you're more confident to diagnose breast cancer. So apart from that, so your sensitivity and specificity for cancer diagnosis increases. And apart from that, typing of the cancer becomes easier. So you can say whether it's a invasive breast carcinoma NST or lobular carcinoma mucinous, it's easier on the core biopsy. Grading can be attempted. Usually we give a provisional grade on the core biopsy, but that can go up or down if on the excision specimen. But usually we try and attempt grading on the core biopsy. And the other additional feature is on the core biopsy, FNAC, you won't be able to discriminate between DCIS and invasive carcinoma, because both are all DCIS and invasive carcinoma both become C5. So, but on the core biopsy, you have definitely in most cases you can identify whether it's DCIS or invasive carcinoma. And the other advantage is, of course, performing IHC on the core biopsy. So we usually, after cancer diagnosis, we usually perform the breast markers and the Ki-67 on the core biopsy as well.
Okay, madam. Other thing is, in her report, the HER2 is 2+. How do you further evaluate this? And what are the facilities available in Sri Lanka to further evaluate this?
So if it's HER2, 2+, it has, we recommend FISH testing or either ISH testing. So currently in Sri Lanka, garment sector, we don't have a system to perform FISH testing. Apart from, I think, Anuradhapura, Nurad must be knowing, they have started dual probish as a trial. So hopefully we are also like, Nurad can speak about that. I think he was suggesting that we should start, even at suggesting 3 centers to do a dual probish test, which can be done on our immunohistochemistry machine. So we are hoping that we can start that in the future. But at the moment, even at Maharagama, we don't have FISH testing. Yeah.
Okay, madam. One more question. How about the access to the IHC facilities in peripheral hospitals?
Yes, peripheral hospitals, all provinces, national now, Maharagama is not a national immunohistochemistry lab. We usually get referrals from clinics and so on, but we do peripheral cases, but come in only through our clinics. But national immunohistochemistry lab is there at NHSL, and they provide an island-wide service. And also there are immunohistochemistry facilities in other provinces as well. So even in Jaffna, there's an immunohistochemistry machine. Anuradhapura has. Most centers, Kandy definitely has. But there are few centers, I think Batiklo doesn't have, and they had a problem getting down the machine. But in those centers, they can, Karapiti also has, they can refer it to the closest hospital, closest center where they can get the IHC done. But off and on, there are problems with supply of reagents. Even at Maharagama, we actually buy reagents on local purchase. So MSD is not providing at the moment. During COVID time, we had a big problem and had to appeal to donors to supply, give the reagents. So immunohistochemistry expensive. So, if you get another biopsy, don't send it to another place and get another IHC done. Always make sure that if it's done, get down the report from there, because it costs money. So, yes. So, I'm hoping in all your centers that you have access to immunohistochemistry, even though I know some cases it takes a long time. I have heard, yes.
Madam, actually, what is the use of doing both ER and PR receptors?
What we do is basically the international recommendation is to do ER, PR, HER2, and T67 all together. But with actually with the reagent problem, I think the College of Oncologists and College of Pathologists got together and devised a plan, and we thought we would only do ER first, and if it's negative only, we would go for PR. So we will do ER and HER2 first, and KI67 on selected cases, like, if it's luminal ER positive cases, early stage breast cancers only we would do. But I think it is first we usually put ER and HER2, and yeah. So if the oncologist only asks for PR, we would put PR as well.
Then, madam, how long will it take to issue a biopsy report and IHC report? The usual time?
Usual time, usually in most labs for biopsy report, they would say 7 to 10 days. But if you're really in urgency, like, if you call the pathologist and ask, if you ask me how urgently can you do this? Sometimes there are times I have given the report even in 3-4 days. So, but fixing is very important. So even if you're in a rush, if you're in a rush, never compromise the time that you fix the specimen. So what I do is, if it's done today, I definitely make sure it's overnight fixed and put it to the machine, ask technicians to put it to the machine the following day. Because if you compromise on fixation, then your HNE section is good, but then your IHC won't work. So that's the issue that we have. IHC, again, it's a matter of the workload of the lab. So if you want it done today or tomorrow, like if you want it done in 2-3 days, they can do it. But the issue is depends on the workload, and the individual center is different. So I think in private sector, they say around 10 days for IHC report. And Maharagama, we say 2 weeks for this thing, but to issue a IHC report. But obviously there can be changes depending on the workload.
Okay, thanks, madam.
Right. So we move to Dr. Nurat next. So can you explain what is the importance of biopsy and the information we get from biopsy for the management of this patient?
So, well, the first, I think Priyanka madam has explained. So, the distinction between DCIS and invasive cancer is the first reason. I mean, that's very important. So, once you've diagnosed an invasive cancer, I mean, tumor biology is one of the primary things we look at as an oncologist. So, we categorize it based on immunohistochemistry into luminal A, B, triple negative, and HER2. So if it's triple negative and HER2, and the tumor size is more than 2 centimeters, or if it's node positive, we would recommend as standard practice neoadjuvant treatment. Unless you can still go ahead with primary surgery if there are reasons to do that. But generally, if it's triple negative or HER2, you would want to, the recommendation is to give neoadjuvant unless it's a T1 and not tumor. So again, the distinction between luminal A and B, that's important, because if it's luminal A, we would be very slow to consider any form of chemotherapy, whether it's neoadjuvant or adjuvant. So we would reserve that for the very locally advanced cases or tumors with a heavy nodal burden. Luminal B is a borderline category. Again, you have to weigh the benefits of adjuvant chemotherapy. Luminal B, HER2 negative tumors. So as oncologists, the co-biopsy and it plays a very pivotal role in deciding our management.
Okay, sir. And next question goes to both surgeons and the oncologist. So what is the role of MDT in breast cancer management? Nurat, sir?
Yeah, so I think MDT plays a very pivotal role. You heard about all these, especially in our setting, and I found in my experience that it is easier to do these MDTs at sort of district general hospitals rather than in the bigger hospitals. Partly because you have the whole team there, and it's easy to do it at a small hospital. So all your problems like getting a mammogram, all of that you can bring to the MDT. So if you have a clinically suspicious tumor, you can then bring it to the MDT, and the radiologist very often will, even if mammogram is not available in your center, we will speak to the closest center and arrange an urgent mammogram that can be done. The same with doing a biopsy, if you want a clip put in, all that can be sorted. And immunohistochemistry, if you're thinking of neoadjuvant and you want to want the immunohistochemistry report soon, again, the histopathologist can fast track it for you.
Conscious, sir, what is your, sorry. Conscious, sir, what is your opinion on this matter?
Yeah, I mean, as Nurad said, I think having MDT discussion is a very useful thing. We do that because now, especially now in cases, as Nurad said, this in cases like where there are triple negative, HER positive, I mean, there's a special place for giving neoadjuvant. And there are some cases where we need to discuss, like he said, luminal layers sometimes in older people, especially, and whether they can tolerate neoadjuvant. Then we discuss with them, is it now, though the tumor is the larger, is luminal layer, and would you consider chemotherapy? I mean, generally they may not. So under those circumstances, sometimes even somewhat advanced tumors, we operate primarily in older patients where the advantage of the neoadjuvant would be less. So that is like that. There are different situations, and about getting clip placements and getting memos and getting guided course. As Nurad said, we had very useful situations where we can get our radiologists. We just talked to Rupa, is it possible to do it today? I said, okay, we'll do it today. By that time, the urgency of the case can be stepped up by doing that. Rather than just putting urgent on a label, if you have the patient in the MDT, it's obviously urgent. So the participation and the support of the team become very much active if you have the MDT discussion. And also it's a timing of the surgeries and other things also can be planned in, because if they are going to, now the issues is sometimes getting these cases in operation list for surgeon is another issue. So I mean, then ideally, if you know that this patient is coming, you can try and keep a slot. So for various purposes like that, MDT discussion is mandatory, and I think it's a very useful thing to have. Yeah.
Yeah, I would like to add just two other points. First thing is that it is important to discuss every new case as far as possible, because what you think, I mean, there may be issues that your other colleagues in other specialties will see. So as far as possible, you should try to discuss every new case, not just the cases where you think are interesting or where you think there might be a sort of a multidisciplinary input needed. So, and if you have it weekly, it doesn't take much time. And the other thing is that every district now we have a oncologist, and as far as I'm aware, in all the district general hospitals, they have MDTs. So even if you are working at a base hospital, you can contact the nearest sort of the oncologist in your district and get access to the MDT and discuss your cases. So I think that would improve outcomes significantly if you do that.
And Dr. Chaturani, do you have any opinion? I think the MDTs are well established in your practice.
So yes, even for benign cases, we discuss in MDT. B3 ones we discuss, all the cancer patients we discuss. One thing is, it's a good learning platform for junior doctors, registrars, senior registrars. They can gather a lot of information. Somebody else is talking. So, and the other thing is, like, when I came here, there are a lot of new things for me when I like to introduce myself. It was really easy because the MDT was there. If there is a complicated patient, everything goes through the MDT. And the other thing is, in this patient, because she's 38, we need to make sure there's nothing going on with the other side, whether she needs like MRI guided biopsies, and so on and so forth. And when we discuss cases in the MDT, we look at the images again. So it's like the third look. Like on the first instance, two radiologists look at the mammograms and the ultrasound scan. But when it comes to the MDT, it's shown again. So all the consultants, oncologists, we all together have another look and ask if we see another suspicious lesion. So it's like a third look so that we won't miss anything. And the other thing is, like, if this lady is going for neoadjuvant because it's ER negative and HER2 was equivocal, but if she's going for neoadjuvant, then we have to plan the surgery. Like, after neoadjuvant, when are we going to see her, and what are we going to do for an axilla, whether we are going to do a central lymph node biopsy or clearance. So we can discuss everything in the MDT, and everything. When we discuss, we put it in a plan and put it into the patient notes. So even though if I'm not there for the patient to be managed, somebody else can take over from there. So if you don't discuss in the MDT, if one person is managing, the patient can be lost to the follow-up as well. So that won't happen if it goes through an MDT as well. So it's important to the clinician as well as the patient as well. Anuja, are you there?
Looks like we have lost the moderators. Let's see.
Hello?
Yeah, okay.
Can you? Okay.
Yeah.
Right. Sorry, there was a technical issue. The next question is for Dr. Nurat. Would you consider staging for this patient? I think Dr. Nurat is.
Can I ask that Anuja then?
Nurat sir, can you unmute yourself?
Okay. I think the surgeons can even answer that question. At what stage you do? Yeah.
So for staging, the guideline is if the patient has a bigger mass, like more than 5 centimeters, or if there is a lymph node. If the lymph node is count on the ultrasound scan is 1 to 3, we offer them standard staging, that is a chest, abdomen, pelvis CT scan with a bone scan. And if the lymph node count is more than 4, we offer them a PET CT. It's simple. If the nodes are not involved, if the tumor is less than 5 centimeters, no staging. For this patient, no staging. But if there is a lymph node, if the lymph node count is 1 to 3, standard staging, CT chest, abdomen, pelvis, and a bone scan, whole body bone scan. If it's more than 4 nodes, we offer them PET scan.
So the number of nodes are from ultrasound scan?
Ultrasound scan. If they are bulky, if they are big, yes, then we go for a PET scan.
Okay, then we have discussed this patient at the MDT. It was a T2N0MX tumor and FISH became negative. So it was decided to proceed with neoadjuvant chemotherapy. At the same time, we have sent the patient for clip insertion to the tumor bed. And our plan is to do a response assessment and go for breast conservative surgery and a sentinel lymph node biopsy.
Anyone of the panel has any different opinion than the MDT outcome? You can comment on.
No, what was this? This is a ER/PR negative, HR, triple negative patient.
It's a triple negative.
Triple negative. Yeah.
Yes.
Yeah, I mean, whether it is a triple negative or the HER positive or any of those things, conservation doesn't affect by the whether it's the receptor sweep. It will affect by the ability to shrink the tumor, the location of the tumor, and the practicality of carrying out the conservation and things like that. Now about the sentinel node biopsy. Now this particular patient, and now the sentinel the pre chemo nodes were actually there's some noise is coming on. Yeah. Can you hear me?
Yes, sir. We can hear you.
Right. The pre chemo the pre neoadjuvant ultrasound finding of the axillary nodes were negative. So therefore the error rate of the post chemo sentinel node biopsy would be actually less, because the issues can come up if the nodes are positive prior to the chemotherapy. The error rate of following the neoadjuvant chemotherapy, followed by the sentinel node biopsy is higher if the nodes are positive before the chemotherapy. Then the nodes have to be marked and clipped, and then you should be able to locate those marked nodes at the time of sentinel node biopsy. So such complication would not arise in this patient because the nodes were originally look negative. So it's I would do I would go with the plan. I mean, the only thing is the central quadrant. So then we have to plan the central quadrant resection, and then maybe a resortive flap. Now, if it's a cup size D, then you might be able to get the flap in. So I suppose it's a reasonable plan, provided rest of the breast is okay by MRI scan or whatever scans that we do. It's an acceptable plan. Yeah.
Yeah, sorry, my computer just froze, so I had to log out and log in again. Sorry, I missed anything you, I mean, I missed part of the discussion here.
Yeah, we will.
No, what I said was this, Nurad. Now, this is a 38. He asked, the question was, the MDT discussion decided to do the neoadjuvant chemotherapy because the fish test has come negative. So it's a triple negative case.
Yeah.
So MDT discussion was to mark with clips and then, you know, and then offer neoadjuvant chemotherapy followed by a breast conservation and a sentinel node biopsy.
Yeah.
So what I said was this patient it has two issues. One thing, it's a central quadrant tumor, but if it is shrunken, we can always do a central quadrant resection with the nipple areola complex, especially if it is lying behind that. And since it is cup size D, we should be able to get a resortive flap pin and you know, covered area. That is possible. And then about the axilla, because the nodes were originally negative, pre-neoadjuvant nodes were negative. So therefore, the error rate of doing a post-neoadjuvant the sentinel node biopsy is less actually. Because if the nodes are positive, then there is a possible error rate of 12% misread can occur unless you do clip marking, dual tracing techniques, and various things. The possibility of missing the positive nodes that were before the neoadjuvant chemotherapy is higher if the nodes are positive prior to chemotherapy. So, but since this patient had negative nodes, that risk is much less. So it should be the same as doing a sentinel node biopsy in a patient who hasn't had a neoadjuvant chemotherapy. So I should go along with that plan unless they have focal disease or some other problem.
Yes. So a lot of people ask this question.
And also unless the genetic testing was done, and then you took a separate decision of whether you are doing bilateral mastectomies and various other things, which is in our country we can't get the genetic testing immediately done. It takes a load of time. So if you take a decision like that, then of course you can always do the mastectomy, bilateral mastectomy if you are going to do a.
Excuse me, sir. Actually, we are planning to discuss genetic testing later, sir.
Yeah, that's what I'm saying. Unless you have some problem like that, you would do. I suppose I would go with the plan. That's what I said.
Yeah. So I think a lot of, I mean, surgeons ask me this question: if you have got an operable tumor, in the sense that perhaps you could do an upfront conservation surgery, why do you need to give neoadjuvant chemotherapy? So that is a question that we get asked. So if it is triple negative and HER2, so there are lots of reasons. First of all, if there's tumor shrinkage, you may be able to reduce the volume of breast tissue that you resect. That may or may not be the case. But as oncologists, so the response to the first thing to say is that whether you give neoadjuvant, all the trials, neoadjuvant versus adjuvant chemotherapy did not show a survival gain. So whether you give chemo before or after, that did not improve overall survival, the trials that took place. But we know that complete pathological response is a prognostic biomarker, and subsequently studies were done where you escalate treatment if you fail to achieve a pathological complete response. So, for example, in this patient who has got a triple negative tumor, even if it is operable upfront with a wide local, you would still need to give neoadjuvant chemo, because if you do not get a pathological complete response, then you can see that's a poor prognostic marker, and that is a group where you want to escalate your systemic treatment adjuvant in the adjuvant setting. So you can give things like adjuvant capecitabine. There was a Japanese trial that showed that if you give adjuvant capecitabine to triple negative patients that fail to achieve a complete pathological response, you will have a better survival. The same with HER2. You can escalate treatment if you do not achieve a PCR. So that is why in our guidelines and international guidelines, generally, if it is triple negative and HER2 positive, neoadjuvant chemotherapy is recommended.
Can I ask a question from Nuraj? Now, if it is this one, if the fish has come negative, if the fish came positive, would you just do chemotherapy only, or would you add trastuzumab as well?
We would definitely add trastuzumab. So our standard regimen is something called TCH, trastuzumab, docetaxel, and carboplatin. If we do not have pertuzumab, it's very expensive. It's not funded in our setting. But we're looking at least for the neoadjuvant setting, if the prices come down, we might be able to get pertuzumab for the neoadjuvant setting at least. Yeah. So definitely we would definitely give trastuzumab. Yes, we would give definitely trastuzumab. We would give in the neoadjuvant setting.
No, I mean if you had pertuzumab, you would be giving a dual blocker.
Absolutely, yeah.
And Nuraj sir, the subareolar lesions close to the nipple, are there anything that we as surgeons be precautious, or are there any contraindications for breast conservation?
So I think maybe a surgeon should answer that, but I have seen a lot of surgeons saying that when there is a subareolar tumor, they are reluctant to do sort of breast conservation surgery. So I think that is a sort of an area where you have to probably focus on. So we as oncologists would prefer breast conservation if it is feasible over mastectomy.
Can I add something Dr. Nuraj said earlier? So we were talking about complete pathological response, and surgically when you do a sentinel lymph node biopsy after neoadjuvant treatment, and if you find macrometes, you clear the axilla. That's the usual guideline. Even before neoadjuvant, if you find a macromete after a sentinel lymph node biopsy, you clear the axilla. But if you, in these patients, when you had neoadjuvant, if you find micrometes or isolated tumor cells, you need to clear the axilla. That means after neoadjuvant, there is residual chemo-resistant disease. That means not a complete pathological response. You will need to clear the axilla. That's the standard guideline. It has not changed. So if you have done a sentinel lymph node for a neoadjuvant patient, if it becomes even positive with micrometes, isolated tumor cells, you need to clear the axilla. It's not radiotherapy. You need to clear the axilla. That's just guideline.
Nuraj sir, you just said that oncologists are preferred breast conservation over the mastectomy. Why is that?
Yes, so earlier, I mean, there are lots of trials that have shown that breast conservation surgery is equal to mastectomy. But now there is evidence from large population studies that show that actually breast conservation surgery is superior to mastectomy in terms of cancer-specific survival. Not only is breast conservation equal, it is actually superior in terms of, I'm not talking of only overall survival, but also cancer-specific survival. So it is believed that the sort of, when you remove lots of tissues, there is a sort of a metabolic response to the surgery, and that creates a conducive environment for any tumor cells to metastasize. And also breast conservation is always accompanied, almost always, by adjuvant radiotherapy. So adjuvant radiotherapy may have a sort of an immune stimulatory effect, so that your distant metastasis will also get the micrometastasis may be cleared. So it is important when you are counseling patients, it's important not just to say that both are equal. You have to tell your patients that the data suggests that breast conservation is superior. I can just show you very quickly the survival curves if you allow me to share the screen. Is that okay? Yeah, yes. So I think a lot of the time, if we just say breast conservation is equal, patients may opt for mastectomy. They think getting rid of the tumor, getting rid of the breast will sort of sort it out. And even a lot of oncologists say that you can avoid radiotherapy by doing a mastectomy. So all those are not valid arguments. So let me just share this slide for you. Yeah. Okay. You can see the slides, right? So this is the breast cancer guidelines, which Kanishka sir and lots of oncosurgeons and surgeons, pathologists, all of them were involved. This is the national guidelines for our setting. Let me just, I'll just show you the algorithm for neoadjuvant treatment. So any T2, if it's T1 N0, you go for breast conservation surgery directly. Anything else, if it is HER2 or triple negative, you need to go for systemic neoadjuvant chemo. So this is what I want to show you. So this was published in JAMA Surgery. Now, if you look at it, right. Can you see the arrow pointer? So so the first one is tumors less than 2 centimeters, breast conservation surgery is superior. This is mastectomy for less than 2 centimeters. So these are both same category. You can see breast conservation, the breast cancer specific survival is more. It's not just, so you can't attribute to things like psychosocial outcomes are better and so on. So even cancer specific survival is superior. So definitely doing a mastectomy may be harmful. If you can avoid it, and if you can do a breast conservation surgery, you should always do it, because not only is it outcomes are definitely equal, but it is probably superior. There was another study again in Lancet Oncology. You can see even for early tumors, breast conservation surgery had a superior metastasis-free survival. So definitely doing a mastectomy may induce tumor cells to metastasize, maybe. So definitely we should be offering breast conservation surgery to all patients if we can do it, if the tumor size and other factors do allow it. Yeah, so that is what I wanted to say.
And the next question I would like to ask from Kanishka sir and Dr. Chaturani. Sir just mentioned about a Grisoti flap. So always for a central resection, would you do a Grisoti flap, or can we close it primarily if we have enough breast tissue? What is your opinion?
I mean, you can close it primarily, but the problem is the breast will be that it'll like a truncated appearance will occur. So, but if you can put a Grisoti flap, it will be like a puckered central area. So unless you take a very small area out, so that it doesn't give the nice cosmetic effect that the Grisoti flap would give. The thing is to put the Grisoti flap, you should have adequate breast tissue. because it's taken from the, I mean, inferior to the areola commonly. It's from the bottom part of the breast. And unless you have good breast tissue volume there, it's difficult to bring the flap up. So it's a type of a reduction mammoplasty type technique where you bring it up and surface the areola thing. So not that it's not impossible to close it primarily, but you will get a better effect if you put the flap in. Yeah.
Dr. Chaturan, you have any other
Yeah,
input for that?
so first thing I would like to know is how far away the tumor is from the nipple areolar complex. So if it's very close to the nipple areolar complex, we're not going to preserve the nipple areolar complex, but still we can do a central excision, take the whole thing out, and then we can reconstruct the nipple and do the tattooing around the nipple for the areola. So that's the simplest way of doing that. Or if the patient doesn't want the reconstruction of the nipple and the tattooing, we can just avoid it, do a central excision, and that's it. If it's away from the nipple areolar complex, if we think we can preserve it, then there are a lot of options. One is round block. You can do like a round block dissection, go around the nipple areolar complex, remove the central part of it out, and mobilize the tissue. And you can either do a vice pattern. You can put a primary pedicle or a secondary pedicle, or you can do a vertical scar. So depending how much you have ptosis, how you can mobilize the flaps, there are a lot of options to do, not just one. And if this is like a small breast, if this is not, the cup size is not D, you can remove the breast lump with the surrounding tissue, and then do a secondary flap and do a LICAP or some local flap to cover the secondary cavity. So there are multiple options, not just one.
Yeah, one little thing to add to Chatu. Actually, when the tumor is closer to the areola, just outside the areola, and you take a wide local excision and you use the radial incisions, then the nipple areola tends to get pushed to the opposite side. So another you can use is the racket incision can be used to reposition the areola towards the slightly away from the incision. Otherwise, it gets puckered and lifted up. So
yes, so we go all around the nipple, like in two circles all around the nipple, so it's symmetrical, or else a vertical scar or a vice pattern.
Yeah, so it's like a racket. It's like a round block technique combined with a vertical scar. Yeah.
The problem with the racket handle is you can have a bit of lymphedema if it's extending laterally, lymphedema of the breast. We have seen it in quite a few cases. So we have to refer to the lymphedema clinic and all. So usually we try to avoid it.
I'll discuss.
Next question goes to Anurag sir. Sir, please enlighten us on neoadjuvant therapy in breast cancers. What are the indications? Why it's important?
Yeah, so I think so we discussed some of these points. So any tumor more than 2 centimeters, if it's triple negative and HER2 positive, you should consider neoadjuvant because you have about a 50 to 60% probability of getting a complete pathological response, and that would make surgery very much easier. And also, it is a prognostic biomarker. You can escalate treatment if you fail to achieve a PCR. And the other indication would be if you have sort of a very locally advanced tumor, like a T4 tumor with or an N2 tumor with fixed axillary nodes, then obviously you really have very little choice but to give neoadjuvant chemotherapy. If you've got a operable tumor with a sort of a which is ER positive and HER2 negative, you're sort of it's borderline resectable, then sort of you're thinking about breast conservation or mastectomy. Again, if it is luminal beam in the sense that it's ER positive and you've got your Ki67 is high, then you may consider giving neoadjuvant chemotherapy to downsize the tumor so that you can go for breast conservation surgery. So those are some of the indications for neoadjuvant systemic treatment. If the tumor is less than 2 centimeters and node negative, you don't need to. That's a group where you can proceed with the upfront surgery.
Okay, sir. So how would you do a response assessment? Do you routinely do radiological investigations for response assessment?
We so in our setting we do a ultrasound scan and a mammogram, but ideally I think maybe Chatu and Lakpati can enlighten us on this. You ideally would so in the center that I worked in the UK, an MRI was also done pre-neoadjuvant and post-neoadjuvant, so that you can see the response better. But in our practice, we, I mean, even in Hambantota, we do a ultrasound scan and a mammogram post neoadjuvant also.
The next question goes to Lakmali Madam. Madam, what is the best tool to assess response? Is it mammogram or MRI scan?
Yeah, the best tool is definitely MRI scan. MRI most accurate dimensions of the tumor in size because even the ultrasound mammogram even the ultrasound can give a false enhancing part of the mammogram. MRI will be the best way to accurately size. So although there are in aesthetic to do a pre-op and pre-chemo and post-chemo MRI is not usually feasible. Therefore, what we usually do is ultrasound and mammogram. That's the tumor size. So if you have a pre-op, then of course with mammo and ultrasound, come to a whether how much reduction has happened.
Kanisha sir, what is your opinion on the repeat mammogram after neoadjuvant chemotherapy?
Yeah, I mean, the thing is, repeat mammogram can be done. One thing is getting a repeat mammogram is not always practical. So that is one problem. In that, say, I mean, since if we are going for, if we had a microcalcification, especially outside the tumor, or lot of microcalcification in association with the tumor, having a mammogram would be helpful to see whether the tumor has shrunken and whether the microcalcification is lying how much outside the clip placement. So then at least you might be able to get idea about how much area that you are going to dissect, because subsequently you will have to do a specimen mammogram if that is the case to assess and see or whether all the microcalcification inside. So in that case, it will be quite helpful. But at least, yeah, I mean, ultrasound scan also will give a reasonable idea. I mean, we can't get MRIs on post chemo patients. It's very difficult to get that. So at least ultrasound scan would be helpful. Then if you know at least the tumor is gone, because the thing is now, if the tumor is gone, then we'll have to locate the clip. So to locate the clip, we normally use the ultrasound scan, and if the ultrasound scan can't pick up the clip, there have been some instances where they can't see the clip, then of course a mammogram will have a special place, because you'll have to locate the site where you are going to excise the area. If the tumor has completely shrunken or something like that. So those are the main reasons why we would have advantage of doing a response assessment, mammograms and ultrasound scan prior to surgery. Yeah.
And one additional question, sir. When you assess the response, you wait for the entire neoadjuvant treatment to complete, or do you do a interval assessment after a few cycles of systemic therapy?
I mean, ideally, interval assessment is vital. Interval assessment has to be, the problem is we normally get the patients after the full course of chemotherapy. So we rarely get opportunity to do interval assessments. But I suppose the oncology should be at least doing the interval assessment to see whether it's working or not. Because if the tumor is getting bigger or something like that, then you'll have to decide what to do. So maybe there's a place for internal assessment, but we rarely get opportunity to do that in our setting.
Yeah, so I think that's a good question. So we generally do examine the patient before each cycle. If there is clinically the lump is increasing, obviously we need to change course. Now, previously there was a practice where you give part of the neoadjuvant, part of the chemotherapy neoadjuvant, then go for surgery and then give rest of the chemotherapy adjuvant, like 4 cycles and then surgery and then 4 cycles of adjuvant chemo. That is no longer the practice because so we generally give the full course of chemotherapy upfront, and the only reason to stop it is if the tumor is increasing in size. Because again, if you're using your pathological complete response as a biomarker to escalate treatment and so on, you need to give the full course of chemotherapy upfront. Otherwise, you wouldn't be able to make a proper judgment. So we no longer practice this sort of, I mean, not standard practice to give part of the chemotherapy first and then give the rest after surgery. But we are supposed to examine, I mean, you'd obviously examine the patient clinically. And if you think the tumor is progressing, then you have to send the patient for surgery, obviously.
Can I add something to that?
Yes, of course.
Yes.
Yes.
So to keep it simple, if you have done a baseline mammogram, we assess the response with a mammogram. If you have done a baseline MRI, we assess the response with an MRI. Ultrasound is not a very good tool, but sometimes we combine both of them together. So if the patient has had an mammogram, just the simple one, mammogram, so after 2 cycles, the oncologist will do a mammogram in between. And after the 3rd cycle, he will send me the patient in between chemotherapy for me to assess. So before surgery also, I'll get one set of imaging done and send her back to the oncologist to complete the treatment. So in between, I see the patient one time, and after the completion of the or completion of the chemotherapy, I see her again. That's how we do it here.
Yeah, I can add a little thing now to what Noorad said. The practice that was used earlier, I mean, I had extensive experience of those days, the oncologist doing 3 to 4 cycles and sending to us. So then we had to, before we send to the oncologist, we had to fix the patient in operation list because we get a therapeutic window to operate. And that puts a lot of stress on the surgical team in the scene. That is one problem. The second one is, I have never seen a complete response in any of those patients. So as Noorad said, it simplifies the management a lot if you completely give, and it obviously gives the advantage of assessing and deciding whether it works or not. So I think the current practice is definitely superior to what was happening earlier from the historical experience I had.
So we do get a window to operate, like it's written there from this period to this period, we have to do the surgery. So we have to operate in that period.
Right. So we'll move on to the next question. This is for the surgical panel. So after neoadjuvant treatment, what are the challenges you will face as surgeons when you do a wide local excision? And at the same time, can you explain the basic principles of wide local excision for breast conservation and the sentinel node biopsy?
You want me to say something on that? Yeah. Now the challenges, the problems, of course, is the when you give neoadjuvant chemotherapy, some patients may have obviously had complications. Now, I mean, their blood counts may be low, so, but that is less of a problem now. Most of these patients are given Neupogen. So therefore, we can always, the blood counts are not a big issue unless they have got MI or some problem like that. So we don't have a lot of problem by neoadjuvant chemotherapy given to patients prior to surgery. So it's okay. I mean, it doesn't mess up a lot. And the issues with when you are doing the resections, the thing is locating the place, as I said earlier. If the tumor has completely disappeared, then of course we have to get it locate the tumor using the imaging. So we get a ultrasound scan, or if the mammo or ultrasound scan, we'll have to pass a wire localization needle into that area. So that's one of the challenges. And then we need to know that we are excise the area properly, correctly. So if the lump is felt, of course, then we can take a wide margin from that lump out. We normally keep at least a finger breadth around, so it's at least a minimum of 1 centimeter around the tumor. So a little more margin is taken, which always when you put it into formalin, it shrinks. So the margin that we get and the margin the pathology see are, for a couple of reasons could be different. One thing, the tumor shrinks, the tissue shrinks when you cut it and put it into formalin. The other thing is there could be the shrinkage of the tumor could be mostly centric, but there is a small risk that there could be eccentric tumor locations around the tumor. So normally I wouldn't go cut the line and just go outside the tumor. So I would take a reasonable margin from the original, the mark side, so that we don't cut across the tumor bed or something like that and end up with positivity. And then once we take the tumor, the excised area specimen, we need to orient it before we remove it, or we drop the thing or something like that by mistake. So it's very important. Personally, I of course mark the tumor while it is still fixed to the mark the specimen while it is still fixed to the body, so that inadvertent dropping of the specimen and not knowing which side is up and down doesn't occur. So we mark at least, if we have taken a skin island, then of course we mark two sides. But if the tumor is inside, and if we have taken the whole breast tissue surrounding without any other indication to say the upside is up or down, then we have to mark 3 sides. So you can put, if you are marking 2 sides, short, superior, and long lateral is commonly we use, because the pathologists need to know our marking and we need to clearly indicate in the specimen form. Otherwise, they won't be able to orient it. It's for any conservation. So if you mark 3 sides, okay, you can put 1, 2, 3 stitches or whatever thing, but you must clearly indicate in your specimen form. And also, once you remove the tumor, you immediately put it into the formalin. If it's a big area, like it's a breast or something like that, let us slice it. But a small sample, you don't have to wide locals, you don't have to slice it. You can completely embed it in the formalin. And then important thing is to mark the tumor site with excised area with a clips, so that the oncologist will be able to locate it, especially for booster doses of the radiotherapy. So that's a very important thing. And some surgeons do this cavity shavings, but the problem is I personally don't do separate cavity shavings, because unless you orient the cavity shavings, you wouldn't know which side of the shaving is inside or which side is outside. So it can confuse matters. So what I do is, if I want to take additional margin, I fix it, orient in the same way onto the specimen. So so these are some of the variations of the whatever it is you need to clearly mark the edges. The sentinel node biopsy, of course, is a standard which done. You can use we commonly use methylene loop. Because we don't have the patent loop available, and adding up radioisotope with a dual tracer, of course, would improve the outcome. But the problem is sometimes we can't get the tracer in. So most of the time nowadays we do the single technique. And I personally use another additional. I put my ultrasound scan in my finger in, and actually most of the time you can feel the nodes. You can feel the nodes if you are very experienced in doing this, like we have done like 1,000 or whatever thing. So then you know where the node is actually. So when you put the finger in and palpate, before you see the node, you know where the node is. And there are some special places where you get the nodes. One is below, deeper to the axillary tail is a very common place. That's the first point where the axillary tail enters the axilla, where it causes the pectoralis major muscle. And then commonly you get the nodes in where the dye comes under the deeper to the tail. And sometimes you can see the dye nicely coming superficial to the tail, and then it generally drops into the middle of the axilla or bottom part of the axilla. And then you can see sometimes the dye come across the pectoralis major muscle, and it drops normally to the upper part of the axilla. So if you done a lot of these cases, you know where these nodes are. So this is sort of the thing, the standard way we do.
And yeah, thank you, sir, for the descriptive information. And one more thing, and this is for Dr. Chaturani as well. And do you routinely assess the specimen with some sort of imaging before you complete the excision? Like specimen mammogram or ultrasound scan of the specimen?
Yes, routinely we do. That's the standard of practice. Like there are two different machines. One is Faxitron, where you can take like a 2D X-ray, and there's the Mozart. Mozart, you can take like a 3D X-ray. It gives you in slices. You can play it's like a video. You can play and see which level is very closer. So I agree with all the things Kanishka sir said. Like he was my teacher as well. So you need to mark the specimen, and especially when you mark the specimen, if you are taking an X-ray, you need to put some Liga clips. Like we orient them in 3 positions, either anterior short, lateral long, and 2 stitches inferior. So we put 1 clip anterior, 1 Liga clip, 2 Liga clips lateral, and 3 Liga clips inferior. So when you take an X-ray, then you can see which margin is closer. So if you think if there are calcifications, like even if the initial biopsy says invasive cancer with the DCIS, you can have some microcalcifications at the edge. So then we need to do a margin excision. So whenever we do a margin excision, we put a new stitch to the cavity. So we orient the margin and send it away. And there's a newer tray which is called a clean tray, where you can clip the specimen, orient it, and draw a picture so that it's easier for the pathologist to see, like this was the way the specimen was in the breast. So you can put the whole tray in the formalin in a box. So it's a newer thing which was introduced recently, which makes it easier for the pathologist to orient the specimen. And all the other things are similar.
Okay, next question goes to Priyanka, madam. Madam, what are the pros and cons of doing intraoperative sentinel lymph node biopsy?
Intraoperative sentinel lymph node biopsy, we do it for cases which are basically thought to be node negative. We use 2 methods. Once the sentinel node lymph node biopsy is sent to us, we do imprint cytology on the case. Together with we use an intraoperative frozen, frozen section on the sentinel lymph node biopsy as well, and we combine 2 together. Previously, we used to do cytology only when we didn't have the frozen, but now when both are there, we use both methods. I think the accuracy increases with that method more, but of course, there's a rate of missing micromates with both methods as well. But with both together, I think the accuracy of picking up even micromates are better with both methods. So yes, but on a HNE assessment of sentinel lymph node biopsy, I know some countries they don't do sentinel lymph node biopsies, but they do is intraoperative. They do the sentinel lymph node biopsy, and it's done not intraoperatively, and put into formalin and then assist it later as a normal histology specimen. In there, what you do is basically you can get multiple levels, and you can I mean, there's a difference between the frozen and normal histology. Even though frozen is a histology section, the quality of the section varies between the quality. I mean, the skill of the technician, I should say, because some technicians can cut it very nicely to almost like the normal HNE section, but there are problems like, sometimes the edges become ragged and subcapsular sinus we can't see and things like that. There are a lot of artifacts on on the frozen section. So then there's a chance to miss it. So that's why sometimes you get, you have missed a micromet on the sentinel node biopsy intraoperatively when you do, and when you take your histology specimen, you get a micromet on the specimen. So even worldwide, that is accepted around this percentage. You can miss on the, then you have to decide later what to do.
Can I add the thing?
Adam?
Can I add the little thing? Now I can remember
sure,
saying, Priyanka, you saying when you have a lobular carcinoma, you have a special problem with sentinel node biopsies?
Yes, lobular carcinomas can be tricky. Even like lobular carcinoma is a tricky tumor because they are very small cells. They look like very much like lymphocytes. That's why even on the FNAC, it is very tricky. And even in the core biopsy, sometimes they look like small cells infiltrating, and sometimes we put a pan-CK just to make sure that they are epithelial cells. So it's a tricky tumor anyway. So on the sentinel lymph node biopsy also, we are sometimes not sure even on the imprint cytology, and even the frozen section also can be a bit tricky. But mainly in the cytology, it can look like histiocytes or normal lymphocytes in smaller cells. So yes, lobular carcinoma, sometimes when I do the sentinel node biopsies, I make sure that what is the core biopsy diagnosis, and if it's a lobular carcinoma, I try to be extra careful and see whether there's because it's not as easy as a duct carcinoma.
Okay, and in many centers, madam, the intraoperative assessment of sentinel lymph node biopsy is not available. So how do you overcome these?
Yes, but overcome these means I don't. It's intraoperative cytology. Can be done in any center. So it doesn't need any specialized skill. It's not like doing a normal cytology. So cytology can be done, but any center. That was what we used to do even at Maharakama when we didn't have the frozen machine, because our frozen machine was broken some time back. But now we have a new machine, and only the frozen section would be the issue in a periphery, I think, if they don't have the machine. So I don't think there's a big issue in doing an imprint cytology on it. Even any pathologist, if the pathologist is there, you can discuss with her and do a imprint cytology on the sentinel node biopsy. If the sentinel node biopsy is sent to us, if you have a way of detecting, the surgeon can send it to us. I don't think there's a big issue in doing an imprint cytology in the periphery. Intraoperative frozen section on the center, you need to have a frozen machine, and maybe the technician needs to be trained to cut it. So I think cytology was pretty good. There's maybe a slight. Obviously the accuracy increases, but if you want to do if the surgeon and the pathologist can get together and decide, better inform the pathologist on the day prior to that if you're having a sentinel node biopsy, because everybody is prepared. So I don't think there's an issue in the periphery as well to do an intraoperative sentinel node biopsy with an imprint cytology if there's no frozen section.
Can I ask a question from Chatu on this? Now, as we do the intraoperative sentinel node biopsy and take a on-table decision whether to do the axillary clearance or not. Is that now that actually takes the opportunity of having MDT discussion and discussing with the patient. So what's the current practice in your centers?
So it depends on the facilities that the centers have. Here we have the OSNA facility, one-step nucleic acid amplification test, where we check the CK19 mRNA copy count, like if it comes as a copy count. If it's like more than 5,000, we call it like macromet, so we offer them a clearance. If it's less than 5,000, it's a micromet, we don't offer them a clearance. So that is the cutoff point. In Oxford, we didn't have the OSNA facility. All the hospitals in like Royal Marsden has the OSNA facility. If you have the OSNA facility, you can offer the services. But if you don't have it, they go to the MBT and then they have a discussion whether you need to give radiotherapy or clearance and then come back to the patient. So in those centers, you have to have 2-stage surgeries. But here it's at a single go when you have the OSNA facility.
Priyanka madam, there's another question for you. So what is your recommendation for specimen orientation and specimen handling?
Yes, I think Kanishka touched on this, but by local excisions at Maharagama, we oriented. Usually most of the wide local excisions would have a small skin ellipse, so the superficial aspect you would not have to mark, but we usually, the surgeons put short superior and long lateral. But if you orient it, might as well write it in the request form clearly as well, because sometimes some of these request forms, I have seen they forget to write, but make sure you write it there. But if you have a standard, then we also feel that, okay, you have done it the correct way. So short superior, long lateral, and if there's a skin ellipse, no need. But if there's no skin ellipse, you might have to put the stitch superficial or deep aspect 1. So you have to have 3 methods of orientation. Even in mastectomy specimens, sometimes I have seen specimens from surgeons without, like if there's no axillary clearance, it is impossible for us to say whether it's which lateral or medial or superior. So at least superior and lateral you have to mark. So, so orientation is must even in a mastectomy specimen if there's no axillary clearance coming with the specimen. So that has to be done. And the other thing, apart from orientation, another thing I should say here, especially with mastectomy specimen, you better discuss with your pathologist in your center, because it is it is ideal for you to discuss with the pathologist and put a small cut from the posterior aspect vertically in the specimen. This is on a mastectomy, not in wide local excision. Make sure that the formalin goes into your tumor. If you really want to, because sometimes if it's a subareolar tumor, the formalin does not go, like, the tumor becomes autolytic. And if you want to do markers, grading, everything becomes so difficult if the tumor becomes autolytic and the tumor. So sometimes we, unless in most centers, like, the pathologists want, like, some are attended quite late. So in some centers, the samples are sent from one center to another center for pathologists to see. So if it takes a long time, it can become autolytic, and it's better to put a clean cut from the posterior aspect after discussing with the pathologist whether it's okay to cut. But don't put so many cuts so that it will distort the specimen. But at least one cut through the tumor would help to preserve the tumor tissue. Yes.
And can I add a little thing now? This Renuka was also talking about this matter. Now, especially when neoadjuvant has been given, if you do a conservation is different, because then you are sending the tumor area. But if you are sending a whole breast and if there's a complete response or whatever, and the pathologist might find it difficult to find the location of the tumor to do better cuts. So because of that, it is a good idea always to draw a diagram and say where the original tumor was. So I suppose.
Yes, original tumor and the tumor size as well, and so that it's easy for us to find the and co-biopsy findings as well, so that it's easy for us to identify the area and sample the tumor bed. And if the clip had been put in, it's nicer if you tell us that as well.
Yeah. Co-host is
missing.
Yeah. Anuja, are you around? What's going on?
Hello.
Yeah.
Yeah. So we have this patient's final histopathology report, which showed complete pathological response with negative sentinel lymph node biopsy. The Anurag sir, can you just elaborate on the further follow-up and rest of the management plan, and including the genetic assessment as well?
Yeah. So this is a complete pathological response. So this is what we wanted to achieve. So there is no need to sort of escalate treatment at this point. Genetic assessment. So this is a 38-year-old female. So if we would be doing genetic testing for BRCA mutation. So if there is a germline BRCA mutation or a BRCA-like pathogenic genotype, then there is evidence to give adjuvant drug called olaparib, which is a category called PARP inhibitors. So it's quite expensive at the moment, so it is not available in our health system, but there is evidence to say that it improves outcome, and so that's about genetic testing. Systemic treatment, that's the only change that would happen. If it's BRCA mutant, you would give olaparib if it is available and funded. We generally give adjuvant radiotherapy even if you do achieve a complete pathological response. Modern radiotherapy, we give 5 days of for whole breast radiotherapy. Earlier we used to give it, when I was a registrar, it was 5 weeks of radiotherapy. Then it reduced to 3 weeks, and now it's down to 1 week. So this is a 38-year-old female, so we would generally give a tumor bed boost. But again, a lot of controversies on because the tumor bed boost hasn't been shown to improve survival. It just reduces local recurrences. So in a patient like this, where you have a complete pathological response, whether giving a tumor bed boost achieves anything is disputed, and the tumor bed boost trial did not have patients in this category. So 5 weeks of radiotherapy in centers like certain centers, they integrate the boost into the 5-week regimen as well. In other centers, they give it as a sequential. If you're giving a boost, you give another 3 to 5 fractions afterwards. So the message that I want to give is whether after breast conservation surgery, radiotherapy is very often just 5 days, and it is very safe. It has very little side effects, far less than chemotherapy. You just get a bit of redness, tenderness, and maybe a little bit of tiredness. So it is not a reason to do mastectomy. I mean, avoiding radiotherapy is not a big advantage, because radiotherapy is a very safe treatment and it's only 5 days. Earlier, it used to be 5 weeks. So we as oncologists were very concerned. It takes 5 weeks of our radiotherapy machines, but now it's just 1 week. It's 5 days. So do not do mastectomies to avoid radiotherapy, because that is the key message I want to give as an oncologist. Please do breast conservation surgery as far as possible. I've shown you the data, and avoiding radiotherapy is not a big advantage, because it is of all the treatments that you have, compared to systemic treatment, it is very safe. So we would give adjuvant radiotherapy and follow up. We would just, we would obviously follow up the patient clinically every 3 months. Generally, ideally, we should alternate the follow-up with the surgical team, so that, maybe the oncologist sees 6 months and then the surgeon sees 6 months, but it's alternate. So every 3 months, one of the teams would see the patient. If it's breast conservation, I don't know what the practice is in the UK. We would do an ultrasound every 3 months, at least for the first 2 years, where there is a high likelihood of local recurrence, and an annual mammogram for 5 years. That is our practice. I have to also say that, so ultrasound of the breast and axillology. So we have seen sometimes during follow-up, mainly it's the oncologists that are guilty of this. we do ultrasound abdomen and chest X-ray every 3 months. The patient gets an ultrasound abdomen and a chest X-ray. Now that there is no evidence for such a practice because breast cancer, metastatic breast cancer, as it stands today, is incurable. So there is no real particular advantage in detecting a liver met or a lung met early. So there is no point in an asymptomatic patient doing ultrasounds and chest X-rays every 3 months. That is just going to just block all your ultrasound and X-ray slots. And when you really need something to be done, you won't be able to get it done. So there is no evidence to do routine ultrasound or chest X-ray during follow-up. It's just mammogram. And in the case of a patient with breast conservation surgery, we generally do ultrasound of the breast every 3 months.
Can I add a little thing? Now, when you do the mammogram after radiotherapy, I mean, especially when when they give the 4 weeks, 5 weeks radiation, there's a lot of edema. So I would normally tell the patients when you do the mammogram after radiotherapy, better to avoid at least about 5-6 months for the edema to settle down completely. Otherwise, we get error reports. And then we were told to do biopsies and various unnecessary complications. So this is something I have seen. So I tell the patient better not do it too early. Otherwise, the advantage of doing it, I mean, it creates a complication. The second thing is sometimes when you do these things, now when we do subaerial injection of these dyes, especially the methylene blue, you get a thickened area subaerially. That is due to the inflammatory response created by the dye itself. So and sometimes that creates a concern, and patients are sent to us asking whether we can do biopsies and things like that. So some of these things, when you are doing the follow-up, you have to take these findings with the clinical judgment, not just the face value of the investigation. So that is why it is very important to have a discussion with the surgical team, because the surgical team, of course, know what they actually did on the breast. So I know the oncology team would know, but the thing is, surgical team would exactly know what they did. So therefore, I think a surgical input is a very important aspect, especially interpreting the imaging and what to do with that. Yeah. Right.
Can I add something to that?
Yes, please.
So if we go back to the genetic, because this patient is 38, we would recommend genetics at our first MDT before surgery, because the genetic assessment takes at least 4 weeks, even if it's done in the rapid pathway. So we do the whole panel testing, not just BRCA1 and 2, several other genes, P53 and KRAS and everything. So because of that, we do it upfront. So by the time the patient finishes neoadjuvant and come back to the MDT, we have the BRCA report with us to discuss. So we had a similar case. She was 38 years old and she was BRCA2 positive. So then we have to decide what are we going to do. So her outcome the prognosis will depend on how well we treat the cancer, not on the breast reduction surgeries. So if we try to reduce the other side at the same time, she might have a complication on the normal side and her adjuvant treatment might get delayed. So what we recommend is to treat the cancer as for any other patient, do a wide local excision, look at the lymph nodes and get this over with and complete her treatment. But we would not recommend radiotherapy because the next step will be risk reduction surgeries. So in that patient, if the BRCA is positive, radiotherapy, we will not give radiotherapy. We will consider risk-reducing mastectomy. So this will not, so that she will not need radiotherapy. So the pathways become different if you do genetic testing upfront. So that's one of the things. And follow-up wise, when everybody who has a wide local excision, we don't do ultrasound scans as follow-up. Even after radiotherapy, we don't. They get a mammogram. We call it the surgical birthday. When they had the surgery, next year they'll get the same day mammogram, same month mammogram. Like 5 years down the line, they get the mammograms. And surgeons see them 6 months and annually thereafter for 5 years. So that's the usual follow-up pathway for the surgery.
Yes, I think we have completed our first case. I don't think we have more time to discuss any new cases. And we got a few questions, and some of the questions already been answered. Heshan, do you have any other questions?
I'll check that. I'll check the questions. One question. How do you treat the axilla in case of complete pathological response after neoadjuvant treatment?
That's a funny question. So to call it complete pathological response, you have to have this pathology specimen. Are you talking about the complete clinical response, like the radiological response?
Actually, that's the question, actually, madam.
Okay, so the person might have meant like there was like lymph nodes to start with, and after neoadjuvant, there's response seen in the ultrasound scan. So if that happens, so usually we plan it beforehand. If the nodes are there, nodes are bulky, we take the decision before giving neoadjuvant. This patient will need wide local plus and axillary clearance. But if there's 1 or 2 nodes, we think we can remove it after. We can remove it after neoadjuvant. We'll clip the lesions and make sure that we take the sentinel node properly. But usually our MDT tends, it depends on the oncologist as well. Usually our MDT tends to recommend axillary clearance rather than clipping. We rarely do clipping and taking them out. We most of the time, if there was node positive bulky disease, those patients end up with a clearance. So to call it pathological response, you should have the pathological specimen.
There's another question. What factors you consider to decide on biopsy when imaging is not suggestive enough for a malignancy?
So that's why I said, like, we usually don't do the imaging and then examine the patient. We examine the patient first, and if we think this is suspicious, although the imaging says it's not, then we have to go back and examine. Either we have to downstage our clinical grading to say this is not suspicious, or we have to do a clinical core. It depends on the experience. When you have seen like some of breast cancers, when you have examined and you feel this is suspicious, those are the times you consider a biopsy. Not all the time.
Okay, and there are many questions, but I think we have already covered those areas. And now over to you, Dr. Sandhani.
Thank you very much, everyone in the panel, for that wonderful and informative discussion. So we'll conclude the session now. And next one would be on new orthopedic surgery, which will happen on, I think it's on 24th of April, same time, 8 o'clock. So we'll see you there then. Good night.
Thank you for organizing this. Good night.
Okay.
Good night.
Yeah, good night.
Thank you. Good night.
Thank you for all the participants and our expert panel, and wish you a nice day and good night.